So thank you so much for the opportunity to present today. Okay, I only have one disclosure, and it's not relevant to this talk. So we know that, as previously mentioned, the bariatric surgical volume has increased over the several years, and as of 2018, we've had over 250,000 cases, and the incidence of, or the prevalence of sleeves has been over 60% of our cases in 2018. So the interesting thing about the sleeve gastrectomy is obviously surgery we think of as durability versus medical weight loss. And several large series has actually, especially this one, has looked at the durability of actual weight loss with the sleeve gastrectomy at 5 years and long-term studies. And there's not very many studies that actually look at the durability of weight loss. This study looks at patients that are 5 years out from sleeve gastrectomy, and they actually found that the mean percentage of excess weight loss was about 54 to 60% at 5, 6, 7, and 8 years out. And then if you look at this study, this is one of the longer studies that looks at sleeve after about 20 years. And they did a small cohort analysis, and they found in their sleeve patients that the actual excess weight loss was only about 58% in terms of looking at the mean. So we obviously were doing a lot of sleeves, and we want an operation that's more than 60% or more than 50% durable. So what about weight regain and in terms of the prevalence of weight regain? Clappett colleagues looked at 7 years out in terms of their patients who presented for revision at 7 years, and they found that in terms of the weight regain rate, it was over 27% for those patients. And then those patients who they actually screened and they looked at in terms of not just weight regain, and that's part of the problem when you look at sleeve gastrectomy, is truly defining weight regain versus ineffective weight loss. And in this study, they defined their weight loss or weight regain as losing less than 50% of the excess weight loss. But in these patients, they found that for those patients that they actually did revise, about 13% of those patients actually were for weight regain specifically. So there's several factors that obviously it's hard to define weight regain as looking through the literature, but for the most part, there's several factors that are found to be contributory to weight regain after a sleeve gastrectomy. The first one is hormonal, and then there's some patient-related factors such as dietary noncompliance, as well as physical inactivity, and then there's a mental health component for a lot of patients with depression or binge eating disorders. And then there's obviously the anatomic problem. So in terms of hormonal, we know that the sleeve is a resectional procedure, correct? And so that part of that alters our gut biome and our gut hormones. And so we know that removal of the fundus primarily leads to upregulations of PYY and GLP-1 and GIP, and also decrease in ghrelin. And that promotes satiety, it decreases hunger, and decreases PO intake. And interestingly, there's not a lot of studies looking at weight regain and ghrelin levels that actually show statistical significance, but this study actually did show a trend that the ghrelin levels at 5 years were increasing in those patients who were experiencing weight regain as opposed to those who maintained their weight. So pharmacotherapy can definitely be an adjunct for weight regain for those patients who you think meet that criteria. In this study by Stanford, they found the most commonly prescribed medication in their group was topiramate, and they found that starting that medication, even for patients that are 5, 6 years out from their sleeve gastrectomy. And they did look at sleeve and bypass, and they did find that the bypass patients did better on pharmacotherapy versus the sleeve patients, but they did find that they lost about greater than 10% of their total body weight. And then this study here looking at liraglutide, and it's a really interesting study because they looked at their patients starting at 8 years post-sleeve, and those patients had regained weight, and they found that just initiation within the first month of their presentation that they found that those patients did actually lose weight, and then they maintained that weight loss, and it was statistically significant for over a year. So what about the anatomic factors? Dr. Ma had hinted to some of these in terms of just inadequate weight loss and even reflux, but it can be a problem in terms of weight regain. So in looking at the International Sleeve Gastrectomy Expert Panel consensus, they talk about a couple different things that can be anatomic factors that relate to weight regain. The first thing is bougie size. Now, this is definitely controversial within the literature, but what they did come up with that it's likely that somewhere less than 36 or less than 32 and greater than 36 is probably not where you want to be. Greater than 36, they felt that minimizes the restriction of the operation, and therefore you don't get that true drop in the ghrelin levels. And then in terms of retained fundus, so there's a couple studies that have looked at this, and they actually haven't shown a huge significance in terms of weight regain, but I think a lot of the patients that actually show up for revisions, those patients are actually, they have reflux at the time. So in terms of the retained fundus, the most important thing is definitely mobilizing prior to actually transecting and making your sleeve. You need to make sure that you have all of the stomach resected. And then finally, sleeve dilatation. And we'll talk a little bit about this, but this is a little bit controversial. And then upper GI, as was mentioned before, is definitely a great tool for evaluation of sleeve patients for any revision. In terms of surgical management, so the most common operation that's offered for patients who are experiencing weight regain is usually the sleeve gastrectomy, the gastric bypass. And you have to just make sure that these patients don't have nutritional deficiencies and that they're a good operative candidate. So in looking at the data in terms of actual conversion from sleeve gastrectomy to gastric bypass, this paper by Crow et al. Demonstrated that patients who actually come for just weight regain in their series, they actually did experience at 12 months out, they did experience some excess weight loss, and they actually dropped about 8 BMI points. And then this is a hot topic that's been kind of coming up in the literature with regards to weight regain. And those patients that actually have a large retained fundus, is it possible to just revise the sleeve, and will that give them good weight loss? So Gagne's group came up with this algorithm, so starting with a gastrograph and swallow, and then if the patient actually has primary dilatation of their sleeve, so you can see that large fundus at the top, and then looking at them through the volume, so CT volumetry, in order to make sure that their sleeve is actually a large size. So they found it was about 250 cc's. And overall, in terms of their group, they found that at about 6 months after their the re-sleeve, those patients did have about 50 or so percent excess weight loss. This study by Saliba also demonstrated some excess weight loss, and theirs was a little bit higher in terms of their BMI drop, and they looked at it based on BMI. And then finally, this study here shows that re-sleeve is potentially feasible, and it potentially could be durable. They looked at their patients 3 years after re-sleeve, and they did find that those patients had a BMI less than 27, and they were able to maintain their weight loss, and they lost about closer to 85% excess weight loss. So these studies, though, are small. It's like small numbers, 6, 9, 12, and they do also have short follow-up, with the exception of this, it's 3 years. And in the United States, this is not really an FDA approved procedure. So in conclusion, looking at weight regain after sleeve gastrectomy, there's multiple different factors, multiple different etiologies as we talked about. Definitely behavior modification, which is you can attain from a good history and physical exam, and then also considering pharmacotherapy. And then surgical revision based on what their complaints are, as well as looking at their upper GI, can be definitely beneficial to determine if they're a good surgical candidate. Thank you.